Primary, secondary, tertiary, it's difficult to say because primary care is a very different ball game where not in too many countries insurance kind of system have been used. They've used capitation and these kind of methods which have worked very well. And at the same time we have not only primary care but before that prevention and all, that also becomes very critical where government has a very major role to play in terms of preventive and promotive services and primary health care itself. So the insurance can be one of the means to that, but it can play an important role, especially for the, I think, inpatient care, where it can trigger a lot of reforms, but at the same time, of course, the payment of contribution has to be shared between government through tax source and through people through their own contribution.
Hello, my question is to Dr. Aftab. As in India, the TPAs are not tightly integrated with the EHR and all the like that, as far as the claim processing is concerned like that. So how TPAs are prepared to make them paperless claim processing by using the US standards like HIPAA transactions and all the like that. So how we are getting TPAs implemented for that?
I understand that we are lagging behind as far as technology is concerned in insurance sector. However, it is not because of lack of will at our end or lack of IT systems at our end. It's basically the system as a whole. The insurers still want physical copies to audit. What do? We would want, ideally, to reduce our manpower, resources, time, money, everything. We would want an electronic data to flow in from the hospital itself. We probably would look at integration of our IT systems with the hospitals. We also have a mechanism of paperless, cashless. But look at how many hospitals are even following that, even after constant reminders, you know, about a year or two now of training across all these providers. Still, I think we are lagging far behind. The hospitals have not been able to adopt to those systems at all. And the other reason is that even if one single player or two players move ahead, is the industry as a whole which has to move ahead if we have to bring in the changes.
I'll add just one point here. There is one example which we saw, for example, in RSPY, government mandated that it has to be a paperless system. So at least in around 8 to 10,000 hospitals which are part of that, they are sending electronic data without any papers, and insurance companies and TPAs in most of the cases are settling claim electronically. So it's possible, but as he rightly said by Amitabh, it can't be done by one or two insurance companies and all. If as a system it has to be decided, a critical mass has to be reached so that the providers also have to do this kind of, take this kind of approach.
Just to add to this point, I think if you see the first session where Joint Secretary Health talked about National E-Health Authority, NEHA, I think one of the key objectives of the NEHA is to really promote standards and define common way where both private and government bodies can exchange data through viable health information exchange models. So that's something that probably will be solve these challenges in a way. So I think we're completely running out of time, so one last question, please.
Yeah, last question from me. I must compliment all the panelists. But what I am worried for is, you know, the end users that we are. What are we doing as an organization to address the insurance of the geriatric group, which needs the insurance the most? You see what happens the minute you ask for an insurance, be it from a private player or a government player, first thing is they give you the cutoff age. That should not be the criteria. What I feel when we are submitting, you know, the document to the government, in fact, this privileged group should be given that only if companies are handling this group, will they be allowed to get into the healthier segment. What's your take on it, panelists?
One that I completely agree with you that this is one segment which is in a way excluded from the health insurance kind of system. And if the if the premiums either are very, very high or you are not at all, you are getting the insurance. In the government schemes, at least which I know of, there is no age bar. So anybody who is there, who is part of the family can be enrolled. For example, I know only RSBY data. So in RSBY data, roughly 22% of people who are enrolled are age 46 and above. But 44% of claims have gone to people who are 46 age and above. So this is data which I just saw day before yesterday for some other reason, so I remember. Don't think that I remember all the data of the scheme. This is one part. And I think I heard recently that Ministry of Finance is also talking about bringing a new health insurance scheme only for the older people. They are talking about it. But I think that it needs a more holistic approach from the government than just saying, oh, let's give insurance to older people, find some way to do it. It needs a much more holistic approach, because a lot of cost is spent after a certain age in the treatment of the people, and then how that cost is met, whether insurance is the best way or whether bringing an insurance only for poor or only for old people is the best way. I think we need more thought from the government side also on this.
I'll try and answer your question in a slightly different manner. See, historically, why people used to buy insurance? People used to think, I'm not going to fall sick. Why should I need an insurance? And insurance was primarily purchased by those people who were approaching their late 50s, because they thought it's time that I need it. Now, insurance companies and all, when they analyze their data, they realize this, and they came out, the original Mediclaim policy which was there was up till about 75, 80 years. But then the products which came out later during last decade tried to do away or restrict the late entrants, I would say. Not the old age people, but the late entrants. So insurance would not restrict people, but would like to discourage people entering at a very late stage when they really require it. And you know, the principle of insurance gets defeated there, primarily. So it's about pooling of resources and basically paying off claims from there. We also tried to tell various insurance companies that why don't you have a sliding scale of premium, whereby depending on how many number of years a person has been insured, the premium would actually go down and not increase, as compared to what a new entrant would pay at the same age. So there has to be some financial, I think that's happening or has happened.
I think in summary, if you look at, I think there's a strong need, and also time is right for the government to roll out universal health coverage plan. With that, I will end up the session. Thank you so much for the panelists and the audience as well.
Thank you, esteemed panelists and chair. Requesting you all to come to the center of the stage for a picture. Thank you. With this, we come to an end to session 3 and we break for lunch. We shall all assemble at 2 p.m. sharp for session 4 on industry, pharma industry and innovation, IT innovation. Thank you. We now begin with session 4, Pharma Industry and IT Innovation. This session will be chaired by Dr. B.R. Jagashetty, who is a VP Legal Compliance for medlife.com. Requesting Dr. Jagashetty to kindly come to the dais. We also have esteemed panelists, Mr. S.W. Deshpande, former Joint Commissioner FDA and Director General AIDCOC. Mr. Dilip Rajan, GM, Abbott Healthcare Private Limited. Mr. Ananda Sen Gupta, MD, TrackMyBeat.com. Dr. Shishendu Mukherjee, Senior Strategic Advisor Head, Affordable Healthcare, India Wellcome Trust. Mr. Madhusudan Chauhan, Director, Jiva Ayurveda. Requesting all panelists to kindly come to the stage.
Thank you, and good afternoon. I know it will be a lot of difficult after having a nice food and all. So either I will make you all sleep more or sleep less, whatever way you feel. Before proceeding, just to introduce myself, I was the former, I am the former drugs control of Karnataka State, and then I was the national advisor to Health Ministry under Drugs Control Administration, and now I am working with MedLife International Private Limited as a VP Legal and Compliance. The topic given is pharma industry and IT innovation. It is a quite vast topic. Before we proceed further, I request other panelists to introduce themselves. To start with Dilip.
Thank you, Chairman. Good afternoon, and I think as our Chairman said, this is postprandial. Okay, that was done to keep you awake, so no. So I'm Dilip Rajan. I'm the General Manager for Abbott Diabetes Care, and it's a privilege to be here today. Thank you.
I am S.W. Deshpande. I was Joint Commissioner in FDA Maharashtra. I am a founder of organization called All India Drugs Control Officers Confederation. Currently, I am Honorary Director General of AIDCOC. I am into legal consultation in pharmaceutical field. Law is my passion, which perhaps will not be liked by the delegates, so I'll be talking on the regulatory aspects.
Good afternoon, I am Dr. Shirshanda Mukherjee. I work for an organization which is a global charity based in London called the Wellcome Trust. I head the Indian operations, and we are basically a funder, I think one of the odd men outs in this group. And we fund innovations, affordable healthcare innovations, which leads affordable healthcare delivery, drug discovery, diagnostics, and mandate is to provide affordable products. Thank you.
Hi, I'm Ananda Sengupta. I'm CEO of a company called Track My Beat. It's a startup company focused on technology-driven healthcare delivery for remote healthcare, both for rural health as well as for urban health. Thank you.
Hi, I'm Madhusudan Chauhan. I'm from Jiva Ayurveda. We are an Ayurvedic treatment services organization. We've done leverage technology to reach out to people and bring high quality treatment services in Ayurveda to people, and that's what I'll talk about during my presentation. Thanks.
Thank you. We are happy with since yesterday we have heard a lot of things, and considering this pharma industry, in the total healthcare, pharma industry also plays an important role, as you know. It is one of the part. Further, as far as pharma industry is concerned, or other system of medicines, Drugs and Cosmetics Act, as you all know, 1940, it is a misnomer. 1940 is a misnomer, I feel, because the act was formed, no doubt, pre-independence during 1940, and rules were framed during 1945. Depending upon the present situation or according to the situation, there are a lot of amendments have taken place to the act. Not only act, there are nearly about 100 amendments have taken place to the rules also. So it is up to date, but only the thing is name has been kept as it is. However, government is thinking of, because I was working as a national advisor for some time with the government of India, I know better. So government is thinking of bringing out whole act with new name and a new concept. And Drug and Cosmetic Act recognizes the three system of medicines: allopathic, Ayurveda, and homeopathic medicines. When we talk about the Digital India Health Summit, so we have to think of all the three systems. Ayurveda includes Siddha, Unani, Tib, and all. And I'm happy that Ayurveda, one person is there. Further, innovation is also important. Pricing is important. So many aspects are there. Let us start with Dilip Rajan, how it will be helpful for innovation or anything. You can proceed further with IT.
Thank you. Thank you. Again, I extend my thanks not only to Dr. Jaga Shetty, but also to the organizers, particularly Rajendra, for giving us this opportunity. I'm here today to talk to you about a technology in healthcare. I'm here not referring about a technology that's in the pipeline. In fact, I'm talking about a technology that we have just a few months ago launched into the Indian market, a technology that has today enabled thousands of patients already to use it. And specifically, we believe that this technology is not only breakthrough, but in fact, locally relevant. And I'm speaking about a technology not in any other space but diabetes. Now, you'll see here a lot of numbers, or a couple of numbers, and you've heard from speakers, even from yesterday, that there are over 67 million, this is IDF data, but I really want to contextualize that with the number that's in between, which is, that means India today carries over 20% of the global diabetes burden. And it doesn't stop here. What they're projecting is by 2035, we're looking at over 100 million people in India that have diabetes. You've heard from my colleague yesterday, Mr. Jain, talking about the diabetes paradox. But to kind of really dig deep on the diabetes burden, I have a slide here. Now, you could very well do this slide for any country in the world. In essence, what it really is talking about is that significant diabetes burden that India carries. And if you see this slide, in summary, driven by low awareness, driven by lack of compliance, we call it the rule of halves. But what that really means is that people with diabetes, just under half of them are diagnosed. Now, McKinsey projects a data that's 35%. But even if you take the rule of halves, you heard somebody in early 90s, the prevalence of diabetes in India was 1%. Now, ICMR's data indicates that it's now in double digits. And even a recent study that was looking at the twin epidemic of India, both hypertension and diabetes, 2 out of every 3 patients that go into a physician's office today are not controlled. So the question really here is, what is causing this significant diabetes burden? As many doctors in the forum, but more importantly, as you would know, there are essentially 4 pillars of treating diabetes. You have the diet, you have the exercise, but the other 2 aspects obviously is medication. The 4th pillar, which is monitoring. Diabetes, as many would tell you, is a disease of numbers. Now, in India, if you look at the monitoring challenge, and if you can bring it back to physicians, you will see there are tools today. One could be the self-monitoring of blood glucose, which is basically the glucometer that people use. The second one is the lab. Or the third one that many rely on, which is called the HbA1c, or the glycated hemoglobin. What all of this does is to provide a data or an average. What that really means now is a physician today will have to make a treatment decision on their patients based on one or a series of these numbers. Our hypothesis was that this was not enough. We had to innovate. We took over 2 years, just under 2 years, to actually look at a technology that can come into India. And we are now calling this the flash glucose monitoring. So let me just take a minute to explain this. It's basically a 3-component. It's a combination of software, hardware, sensors. Some people call it wearable technology. What it really is there's one component which is the sensor. It's a very discrete, it's just slightly bigger than a 10-rupee coin, a patch or a sensor that resides on the patient. So it has a small little sensor, or what do you call, it's about 5 hair millimeters in diameter. It just resides under the skin. It measures interstitial glucose continuously every 15 minutes, and we have figured this product to work for 14 days. The reader, the one that's in the center, this is a product that resides with the physician. In a matter of seconds, once the patient goes back to the physician's office in day 14 or day 7, all that the physician has to do is to flash the reader over the sensor, hence the name flash glucose monitoring. But we didn't stop there. As you saw, a lot of speakers from yesterday talking about standardization. Rather than reinvent the wheel and create another report for physicians to understand, Abbott in-licensed from IDF, International Diabetes Center, IDC, my apologies, in Minneapolis, a standardized report called ambulatory glucose profile. Now, many of you would realize a lot of awareness is now being created in India. It's not enough to know what was your glucose. It's equally important to know the variability of glucose. In other words, the highs and the lows. You will see that highs and lows physicians are telling about oxidative stress, but there's no real way to measure the highs and lows. This product attempts to do that. And how it attempts to do that is it visually collapses the data. Now, the chart that you see here is basically a combination of, if I just mentioned to you 15 minutes, that means 96 readings into 14 days. That's about 1,300 readings has now been visually collapsed in a single 24-hour period. The importance here is very quickly a physician and or his patient can quickly identify at what time of the day their glucose is fluctuating, the reason for the glucose fluctuation, and last but not the least, provides the physician with treatment options, right? The physician can now, based on the informed decision, can actually change the modality. To kind of really prove this point, I have a slide here, a case. This is published data. It actually looks at 4 patients. They are matched for age, they're matched for type of diabetes,